So I'm going to talk primarily about 6, 8, and 9. I'll dabble a little bit in 7. But let me start by addressing 6. And the crux of that recommendation or that proposal really is both around care coordination and how we think about doing care coordination in this new world of integration, and at the same time pay attention to the supports that people need above and beyond what occurs as part of that integration process. I think I will be the first to admit that some of what we have on the books, we've had on the books for the last 47 years around care coordination is good but a little bit imperfect as the world's gotten a little bit more complicated. And so opportunities under targeted case management, opportunities under the rehabilitation options, opportunities under the primary care case management program, I could continue on. While I think they are good, they have limits. And so I think we have seen how we bump into those limits and how that really can hinder some of our integrative efforts. And I think part of the proposals that we have been able to implement over the last 2 years, 2.5 years, really seek to break down some of those silos. And so as we're beginning to think about health homes and the integration process around health homes, how important it was for us to say, this isn't just about your traditional case management program. This is really being able to think about how do you use care coordination, how do you use case management as a way to integrate not only primary care and behavioral health, but frankly long-term services and supports, because a lot of what we're seeing, a lot of what we believe this program needed to do was to pay attention to the person holistically. And while I think we can talk about that, and we have talked about that as a policy change, I think there's tremendous challenges of how that rolls out at the practice level. And I think we can probably have a little bit of a discussion around that as well. I could list the different programs that we're doing above and beyond health homes. Our challenge at CMS, and I think we're rising up to that challenge now that we've got 2 years under our belts, is how we're coordinating and connecting some of the dots between health homes, the Duals project, the Medicare, Medicaid projects, frankly, who are focusing lots on primary care and other types of integrations. We've got Innovation Center money that's actually underwriting some projects specifically as it relates to health care and people who are homeless. And I'm probably missing some other things. And the good news is that we're paying attention and connecting the dots, and at the same time, we're relying on the knowledge and the approach that ASPE is going to bring as it looks at evaluating some of these programs, so that as we kind of have the next generation, or as we move things out into additional places and people, I think we'll have some good recommendations about how to do that. So that's the care coordination piece. In terms of the supports piece, I really liked how you said more complete and better coordinated health care, because it did recognize that we're doing some of that, but we've got a little bit of a ways to go. And the support piece is tremendously important. I think Estelle and I have probably talked about this at least 8 times in the last month, about the importance of making sure that if you have opportunities for housing, you have the right supports in place. And again, kind of looking back at what we have on the books in terms of programs, regulations, statutes, it's imperfect. And one of the things that we're trying to do over the next 6 months is to be clearer, especially to the Medicaid directors, what are the right supports that can really help people in housing. And I'm glad you brought up families, because it's not just about the supports that folks that have significant chronic conditions need. That's important. But also in terms of families and others that, again, I think are going to be helpful to be clearer. And one of the things that we're doing in-house is actually kind of unpacking what those services and supports are based on some recommendations that a lot of people in this room have given us, and say, how can we cover this? Can we cover this? How can we cover this? How can we be clear about covering this, not only to the state directors so that they're clear that, oh gosh, we can do this, and also what are the limits, because we still have a bit of an imperfection in terms of some of that coverage. Let me talk a little bit about Medicaid managed care plans, and I'm excited, but I also know that there's some challenges as we're moving forward. Obviously, we've got some important benchmarks coming up in terms of dates, and so we are going to have, we think, more managed care plans covering individuals, single adults who are in poverty as part of their plans. Some plans have good experience with that, others don't, and so having them just understand what are the needs of those individuals is going to be tremendously important. More and more states are beginning to move their long-term services and supports into managed care. And I think that it's being met with some excitement, but I think it's also being met with some concern about the extent to which managed care will or won't work for the services and supports that they're going to be asked to manage, and at the same time for populations that they may not have really managed before. And we are working. We have something that we are putting out, guidance. We're not quite sure what the form's going to look like to plans into states about what's the approach should be for managing long-term services and supports as part of the whole managed care practice. We think that's going to be important. Last around managed care plans is really, I think, the increased pressure, and I think, hopefully it's a good pressure that we're putting out there around how you do integration. There's lots of conversations. There's been lots of conversations since the mid-90s of carve-ins, carve-outs. Those are important conversations, but the fact remains is we really want the plans to pay attention to what's happening on integration at the practice level. Because whether or not you've got carve-in or carve-outs, the fact remains is that it's got to work at the practice level, and making as much information and clarity available to those states and plans around what that should look like. The last proposal, and this is the one that's near and dear to my heart, is around substance use. And part of the reason that I came over to CMS was a commitment by CMS that they really were going to pay more attention to substance use disorders. They pay attention to it now. But I think, again, as we move into the future, we're going to have more people with substance use disorders that's going to be covered by the Medicaid program. And therefore, we think that it's going to be important to do two things. One is be clear about what's a good benefit. And for some of you who know my work at SAMHSA, I was trying to be clear about what a good benefit was. But I think we really do want to start around the integration level because I think that's both some of where these people are going to hit the system first and where I think the state Medicaid directors and others are most interested. And so part of it is that we want to be clear. You got to be paying attention to identifying whether or not someone has a substance use disorder or a mental health disorder, regardless of its magnitude, and the extent to which we really want to encourage that to happen, whether that's part of an FQHC or whether that's part of some sort of primary care practice. The second is that we've got some good services out there that have terrific evidence that are being used, not very well used, and we have lots of good evidence around medication-assisted treatment for both opioid use as well as alcohol use. And I think we really do want to be thoughtful about having the practices think about using those, how to use those, when to use those in order to be able to, I think, round out the primary care system. And last but not least, we have to admit that a number of people that have substance use disorders do have the need for long-term services and supports. And to the extent that we can be clear about what those long-term services and supports are for those individuals, I think that will be helpful in really kind of making a dent in folks that are going to be eligible in the future.